Hello, everybody. Welcome to the stream. Today, we're going to be doing questions 1 through 50. I'm going to try to get through these things as quickly as possible. I've taken notes ahead of time on all of these questions, and I also have some community questions, so feel free to ask me questions in the chat, and I'll answer them. But today, we're doing 1 through 50 of NBME 30. These are all original questions that are made by me. Basically, it's everything that you will need to know by the time you've finished and marked off your review for NBME 30. Of course, this does not replace the National Board of Medical Examiners, the practice tests they have there. Definitely complete them. This is just my own original question bank where we're covering topics that you should know by the time you finish your prep. I'm also releasing a website for free, ivmed.net. Be sure to check that out. And if you're interested in the mission here at Ivy Tutoring, then please like and subscribe. It really helps out. Okay, let's do this. So starting out strong. A 3-year-old girl brought to the pediatric clinic. She's got problems with hearing and vision. We covered this before. She has some neural crest migration issues, which are kind of ending up in different parts of the body, kind of wreaking havoc in different areas. One of them is causing vision problems. One is causing hearing, but also they have differences in eye color, like heterochromia. And so this is Waardenburg syndrome, where you have abnormal neural crest cell migration. You can have the black hair with the white forelock. You need hearing aids and have sensory neural deafness as well. It's not albinism, because albinism would not be patchy. Connexin would not be related to pigment, and tyrosinase would not be patchy as well. That's the mechanism for albinism. Okay, so that's the first question. I'm going to try to go a little bit more quickly in the future. But here's our next question. Number 2, we have a 45-year-old man, clinical trial, responses to different nutrients, and he consumes a high-fat meal, and now he has an increase in insulin levels compared to when he consumes a low-fat one. So what explains these observations? So basically, we're increasing the insulin release and more rapid glucose reduction after a high-fat meal. And so the incretin, the GLP-1s, are secreted by intestinal L cells in response to the nutrient ingestion, especially fats or carbohydrates. And so it increases the glucose-dependent insulin release. It also suppresses glucagon, and it slows gastric emptying. So that explains why the insulin levels are rise after you have a fatty meal, and also glucose is cleared faster. So the leptin and the ghrelin, these guys regulate appetite, and the CCK stimulates the gallbladder, and the secretin increases the pancreatic bicarbonate secretion. How about some other answers like leptin? So leptin, that's going to be associated with adipose-derived satiety. Ghrelin, that's going to be the hunger hormone, so the stomach-driven hunger hormone. And CCK, that's the gallbladder constriction and pancreatic enzyme secretion. And so that it helps digest the fats, but wouldn't stimulate the actual insulin release, whereas GLP does. So GLP is secreted from the L cells in the distal ileum and colon, especially fats and carbs, and has a powerful effect on the increasing insulin release while suppressing glucagon. Fatty Liver King says, and specific to the raise in blood glucose, right? Yeah, so GLP-1s are released by nutrients like fat, and they act in the presence of elevated blood glucose. So you have that blood glucose, and that'll boost the insulin and decrease the glucagon, and that normalizes the glucose even faster. Gliptins are another point for GLP-1, says Fatty. Yeah, so this only works when the glucose is high. Motilin would be small intestine, fasting, and M cells. Gastrin is G cells, gastrin the antrum. Secretin is S in the duodenum. And so GLP-1s, they're incretin hormones, and so they're glucose dependent. And DP4 is what degrades GLP-1s. And then gliptins inhibit DPP4s. So Fatty was talking about gliptins. Gliptins inhibit DPP4s, and they prolong GLP-1 action. And so these are used in like type 2 diabetes management. GLP-1 secretion is going to be in the ileum and the colon, and the L cells are stimulated by fats more than they are carbohydrates. And then DPP4 inhibitors in the ileum cause prolonged incretin effect locally and systemically. So since this is the big takeaway is since this is a glucose-dependent mechanism, there's minimal hypoglycemia risk, which is why they're great drugs. And so agonists would promote weight loss, and gliptins are weight neutral. They both reduce the HbA1c in type 2 diabetes. Yep, and gliptins, they guard the gut. They stop you from being clipped by DPP4. So we'll scroll down and see all these answer choices here. Gulp the tiopods. The DPP4s are gliptins, prolonged GLP action. GLP is degraded by DPP4. Okay, I think the questions are generating images now. That's good. Sorry, I had to do some debugging there. All right, in our next question, we have a 67-year-old woman. There she is, presenting to the emergency department with a 4-day history of fever, productive cough, and worsening shortness of breath. Temperature is 102, respiratory rate is 28, decreased breath sounds, dullness of percussion in the right lower field. X-ray shows right lower lobe consolidation. Which structure is responsible for the facilitating the spread of the infection? Yes, I gave you this last time on Twitch. Good, yeah. I was preparing to make this video beforehand on the live stream. Yep, this is the pores of Kahn, right? So the answer is going to be the interalveolar septa. And so here in lobar pneumonia, Streptococcus pneumonia infects a single lobe and rapidly spreads between the adjacent alveoli through the pores of Kahn, which are the openings in the interalveolar septa that connect the neighboring alveoli. And so these pores allow macrophage migration and collateral ventilation under normal conditions, but they also serve as a conduit for pathogens. Okay, so here are the trap answers and why they're wrong. Fatty Liver King says embroncho is the bronchioles. Yes, so the bronchial arteries, these supply oxygenated blood to lung tissue and they're not involved in the pathogen spread. And you're right about the broncho and the bronchioles. So lobar pneumonia is going to be Streptococcus pneumonia. And then bronchopneumonia is like Staphylococcus aureus, H. influenza, Klebsiella pseudomonas. And the spread in lobar pneumonia is it starts in the alveolus and then it goes through the pores of Kahn. Whereas for the bronchioles, it's going to go through the bronchioles to the adjacent alveoli and it spreads along the airways. And if it's spreading along the airways like that, it's going to be patchy multifocal areas, often bilateral or basal. And then if it's lobar, it's going to be the entire lobe. So the spreading is different. Lobar is going to be through the interalveolar connections, and then bronchial is going to be the spread of the bronchioles in the terminal airways. All right, there are the buzzwords here. Streptococcus pneumonia, lobar consolidation, pores of Kahn, decreased breath sounds is a sign of lobar pneumonia. Lobar is looks like grapes and how they spread, how it takes over the whole lobe. So here's our next question. We have a 3-year-old boy is brought to the pediatrician by his parents due to developmental delay, eczema, and musty body odor. Child is born at home and has not had regular medical checkups or newborn screening. So there's the image of our child. What should be supplemented in this child? The answer is tyrosine if he has the mousy odor, right? This is phenylketonuria. It's a deficiency in phenylalanine hydroxylase, which converts this into tyrosine. And so you don't have it, you can't make tyrosine, and you have phenylalanine buildup, and that can be neurotoxic. Tryptophan for serotonin, leucine, buildup involved in maple syrup disease. So this is PKU. It's from a deficiency in phenylalanine hydroxylase, which normally converts phenylalanine into tyrosine. But because tyrosine synthesis is impaired, tyrosine becomes the essentially amino acid that has to be supplemented in the diet. All right, so musty body odor and hypopigmentation and developmental delays are seen. Tyrosine is a precursor for melanin, dopamine, and all these other things as well. Fatty says another point with pneumonia is you get hypoxic vasoconstriction as compensation for a low A to A gradient. Whenever a region of the lung becomes hypoxic, then you have local pulmonary arterial constriction instead of dilation. And so the purpose is to shunt the blood away from the poorly ventilated regions. And so you have better ventilated regions and it optimizes for the ventilation perfusion VQ matching. So in pneumonia, you get alveolar consolidation and the fluid and exudate fill those air spaces and the alveoli are poorly ventilated. And so you have decreased alveolar pressure of oxygen. And so the local pulmonary vessels are going to constrict and you get hypoxic vasoconstriction and that reduces the blood flow to those lobes. Okay. PKU requires dietary supplementation of tyrosine due to phenylalanine hydroxylase deficiency. And here are the notes that I took on this. Mousy odor, what do you give? Tyrosine. So you build up phenylalanine, so you got to give them tyrosine. All right, in our next question, we have our little anatomical model, and we did this on stream as well, but for the YouTubers. So here we have a 68-year-old man presenting with primary care. He's got right-sided flank pain, discomfort. Abdominal ultrasound is performed and shows dilation of the vessels causing compression of the right ureter at the level of the pelvic inlet, resulting in moderate hydronephrosis. Which of the following arteries is involved in this compression? Okay, so if we zoom in here, we can actually see what's going on in this little image that I put right here. There are 3 constriction points: the pelviuretic junction, the bifurcation of the common iliac, which is going to be the answer to this question, and then the intramural part, more distally. And so the answer is the common iliac. All right, so there's the common iliac artery. Compression can occur right there in our little model. And if you have a bruit in your right lower abdomen, you should think of an iliac aneurysm. And hydronephrosis is going to be a post-renal obstruction. And there's a pelvic inlet compression, which crosses the ureter over the iliac artery. And the risk factors are going to be an older man, hypertension, hyperlipidemia because of the atherosclerosis, which can contribute to the aneurysm. So this is going to be associated with atherosclerosis, which is the major cause of this. Also AAA, because this can extend into the iliac arteries as well. And so this can rupture, you can have a thromboembolism, or you can have just ureteral obstruction as well. Celiac would be the foregut supply. Superior mesenteric would be nutcracker syndrome, compresses the left renal vein, not the ureter. Inferior epigastric is the anterior abdominal wall. Gonadal crosses ureter, but it's too narrow to cause that mechanical compression. Okay, there's the bottom line. Compression of the right ureter due to the right gonadal artery is a common cause of hydronephrosis. And here are the notes that I took on this before. And we'll slide on over to our next question, where we're going to have a lot of notes. All right, in this question, we have a 27-year-old woman presenting to the clinic for a routine prenatal visit. 8 weeks gestation based on her last menstrual. She's nauseous. Lab tests show normal complete blood count and serum electrolytes. In early pregnancy, which of the following structures is primarily responsible for the production of progesterone? So early on, it's the corpus luteum. Good, yeah, you nailed it. Good job, Fatty. By the way, his name is Fatty Liver King, so that's why I'm calling him Fatty, not just being mean. That's funny. Yeah, so basically the corpus luteum is going to help in their early stages, and then you have the FSH, which contributes to the follicular growth, granulosa to the estrogen. And so your corpus luteum is fed by that HCG, which maintains it, and then it secretes the progesterone. The progesterone thickens the cervix and maintains the endometrium early on in the cycle. And so what gives here is you have your LH surge, ovulation, which leads to the formation of this guy. The ovulation leads to the formation of the corpus luteum. And then the syncytiotrophoblasts, these guys release HCG, and then it binds to the LH receptors. And the corpus luteum then continues progesterone secretion, and it sustains early pregnancy. And the placenta starts to produce progesterone around week 8 to 10. So early pregnancy progesterone source is the corpus luteum, and HCG maintains it, and placenta then takes over around week 10. And so if you have a corpus luteum failure, then you're probably going to have some sort of a miscarriage. It produces the progesterone, which is super important for establishing the lining. Endometrium is going to be that lining, which produces prostaglandins, not progesterone. Hypothalamus is the GnRH pulse generator. Ovarian follicle is the estrogen producer, and adrenal cortex produces cortisol, aldosterone, and androgen, not the source of progesterone. It's the corpus luteum, especially in early pregnancy. Okay, so there's the bottom line. Corpus luteum, primary source of progesterone in early pregnancy. And this is what it looks like. So now moving on to our next one about relative risk. So if they're saying, hey, what's the risk of, tubal versus oral? You just divide. Yeah, you divide these, and that's all there is to do with relative risk. You take the risk of this, the risk of that, and you just divide them. That's the relative risk. All right, similarly for this one, we actually covered this one on stream. Basically, if we're optimizing sensitivity, specificity, or both, we need to know how we should be moving this cutoff point. And if we have a sensitive test, then that's going to be really good for ruling out a morbid diagnosis. So if there's somebody where most people die like 90%, then you want it to be super, super sensitive, which is the true positive rate, minimizing those false negatives. So like the way to think about this is high sensitivity means that you have few false negatives, because if it's morbid, you're going to want to know that you have it. So it'll catch almost everybody who has the disease. And so if the test is negative, you can be pretty confident that they don't have it, because the sensitivity rules out the diagnosis. So true positive is up and false negative is down. And so you're going to want to cut it off like right around here. That way, the people who are infected, you'll catch. And those who aren't infected, you'll leave alone, but you're erring on the side to the left. Okay, next, the difference between Horner, Gerstmann, Wallenberg, and Weber. So Horner is your classic ptosis, meiosis, anhydrosis. You have a sympathetic chain problem and commonly associated with the Pankos tumor. Gerstmann has agraphia. So here's a look at Horner syndrome. Problem with the sympathetic nerve supply one side of the face results in meiosis, which is constricted pupils. Ptosis, which is the droopy eyelid. And anhydrosis is the failure to sweat. It's that sympathetic chain. Agraphia for Gerstmann. You have right-left disorientation, finger agnosia, acalculia. You have a whole bunch of problems here. And then Wallenberg is the lateral. Pica, vertigo, hoarseness. So Wallenberg affects the pica, posterior inferior cerebellar artery, and the vertebral artery. So this, you might see Horner syndrome, double vision, slurred speech, dizziness, lateral, pica. Yeah, and then Fatty Liver King says need medial medullary as well as Wallenberg. Yeah, that's true. So the medial medullary syndrome, the cause is going to be an infarct of the paramedian branches of the anterior spinal artery. And so it affects the medial medulla. And then the lateral medullary syndrome, this is also known as the Wallenbergs. All right, so that's the pica, so posterior inferior cerebellar artery, and that affects the lateral medulla. So medial, ASA, lateral, Wallenberg. And so just do a little test between these Wallenberg, the lateral and the medial. So if they have dysphagia and they have hoarseness after a stroke, then it's probably Wallenberg. And it's going to be a nucleus ambiguous lesion. And if it's tongue deviation toward the lesion, then it's going to be an ASA stroke, so medial medullary. And if it's contralateral hemiparesis and proprioception, then it's going to be like a medial. And if it's Wallenberg, then it's going to be loss in pain and temperature on the ipsilateral and then the contralateral body. So Wallenberg, pica, hoarseness. The pica horse can't eat is the way you can remember that. Pica, hoarseness, dysphagia. The pica horse can't eat, Wallenberg. And then medial is ASA, the tongue medial. So ASA is the tongue stuff, because you have the cranial nerve 12 lesions for the ASA, which is the medial. All right, now for question 10, dorsomedial aggression, lateral hunger, posterior heat, ventral medial lesions make you massive. So it looks like this person has central diabetes insipidus. They have polyuria, polydipsia, and so it's going to be the supraoptic. This is going to be seen with low urine osmolality, high serum osmolality, and usually it's after like head trauma or neurosurgery is going to be central DI, and this does respond to desmopressin. So supraoptic has ADH production associations. Paraventricular would be oxytocin production. Posterior pituitary is the neurohypophysis, so that stores and releases both of them if they asked about that. All right, so those are the answer choices, and here are the reasons why they are right or wrong. Mammillary would be Wernicke-Korsakoff, causes amnesia. So you have a lesion to the supraoptic nucleus, and that decreases your ADH synthesis. And so you have no ADH release, and so the collecting ducts remain impermeable to water, and you have large volumes of dilute urine. Okay, so there's the bottom line. DI due to a lesion that affects the supraoptic, impairing ADH secretion. And Fatty Liver King says we use water deprivation to test this. Yes, indeed. Water deprivation test is a good test for the supraoptic nucleus because we're going to be producing that vasopressin. The neurons in the supraoptic nucleus produce the vasopressin, and then the kidney responds. So you have a dehydration phase where they stop drinking, because then if they had a healthy supraoptic nucleus, then they would produce concentrated urine. And then if the urine does not become concentrated, then they give them desmopressin, which is a synthetic form of vasopressin, to see if the kidneys will respond. So normally the urine is concentrated, but in central diabetes insipidus, they have damaged supraoptic nucleus. And so the urine is still going to be dilute during dehydration because the supraoptic nucleus is not producing enough vasopressin. And so you give them the desmopressin and it corrects it. And then nephrogenic diabetes insipidus, that's where the urine remains dilute during dehydration, but also fails to concentrate after you give them desmopressin. That's because it's not a problem with the supraoptic nucleus at all. It's just the kidney's inability to respond to the hormone. Okay, on to the next one. We have a 45-year-old construction worker from Arizona. And that honestly is enough to tell you it's coccidioides. Man. Diffuse nodular infiltrates. Yep. We'll just look at all of these and why they're buzzy for each. Blasto, broad-based budding, more common in Great Lakes, Ohio River. Histo is going to be Ohio and Mississippi. Sporothrix is Rose Gardner problem, cigar-shaped yeast. And Streptococcus pneumoniae will be rust-colored sputum. It's a bacterium, not a fungus. Fatty Liver King says really high yield for either hypothalamic and pituitary adenomas causing central. And also, yes, good. Lithium causing nephrogenic, so bipolar is a good cue. Nice. Very, very nice. Really good tips. So, yep, the supraoptic, it'll make the ADH. The post will store a stock, will ship it out. And any break along that highway causes central diabetes insipidus. Okay, here's the bottom line for this question. Coccidioidomycosis causes pulmonary and cutaneous symptoms in endemic areas, confirmed by spherules in biopsy. So California, Arizona gives it away. This would be head and neck. Histo, Ohio, Mississippi, Legionella is gram negative.